Good day, my name is Stella Manuilova. I'm a nurse practitioner student, and today I will present the case of Mr. B, who came to the emergency department with a chest pain. Mr. B is a 47 years old Caucasian man who presented urgently to the emergency department with new onset of severe chest pain. The pain started while he was in the office an hour ago, and he took Tums for it, but at the beginning, but didn't help him, and he was brought by his friend from work. According to him, the pain is located in the middle of the chest, and it is constant pain that has actually gotten worse since it started. Feels as pressing pain, which is very similar to indigestion. That's why he took Tums. On the scale of 1 to 10, having in mind 10 was the worst, is the worst pain, he rates it at 7. He states that nothing actually makes the pain better. And he says also that movements makes the pain worse. The pain also radiates to the left arm and to his jaw. He denies any cough, fever, chills, any dizziness, and less swelling and vomiting. However, he feels nausea, and also he is quite sweaty and feels his heart is beating fast. The past medical history for him is really insignificant. He didn't see a physician for over 10 years. Occasionally, he would take Tums for indigestion, and if he has headaches, Tylenol. No previous hospitalizations, no previous surgeries, no known allergies to any medications. But he has significant family history. His father died at the age of 55 from heart attack, and his mother, she is still alive, but she is on treatment for diabetes and hypertension. Social history: he works as an accountant in a very busy place, and is quite stressful. He spends hours in front of the computer and doesn't exercise too much. He is married. He has 2 children and very supportive family. He smokes 1 pack per day for 10 years, doesn't do any recreational drugs, drinks 1 to 2 beers per week, and tries to eat healthy. On examination, on general appearance, Mr. B is overweight man, and he appears very ill. He is alert but quite anxious and in obvious distress. The vitals, initial set of vitals, showed blood pressure 140/95, the pulse 105 per minute, respirations 22 per minute, and the temperature 36.5. The oxygen saturation on room air was 95%. Because his skin was very sweaty and clammy, initially he was started on oxygen 2 liters for the pain. Aspirin was given for the pain and nitroglycerin, and the vitals, we continue to monitor them. On examination, and also ECG was taken, as well as blood work for cardiac enzymes. So on the physical examination, the skin is found to be cool and clammy, the nails no clubbing, and no peripheral cyanosis. The cup refill is less than 3 seconds. Trachea sits midline. The thyroid is palpable but not enlarged. The jugular venous pressure is 3 centimeters above sternal line with the head at 30 degrees. Carotid pulse is brisk without any bruits, no femoral or abdominal bruits, and the peripheral pulses are 2+, and they are regular. No less edema noted. On the examination of the lungs are clear, no adventitious sounds. The chest, on inspection, there is no any deformity, and no any obvious visible hips, and on palpation, no any tenderness in the muscles on the chest. The point of maximum impulse is found at the fifth intercostal space on the fifth intercostal space at the left midclavicular line. S1 and S2 distant, no murmurs or extra sounds. The abdomen is obese, no visible peristaltis. It is soft and no tender, and abdominal sounds heard in all four quadrants. At this point, based on the presenting history and based on the risk factors that he has, like smoking, obesity, and the significant social and health history, most probable diagnosis is myocardial infarction. That's why blood was taken for cardiac enzymes, and the ECG was started, and we are waiting just for the result. Other differential diagnosis, and we need also to rule out pulmonary embolism, also angina, GERD, and of course, ruling out all this, anxiety could be another part of the diagnosis, as well as costochondritis.